Claire Cantro here with Spread the Well, and I wanted to take a minute to demonstrate some trigger point self-releases for management of a painful shoulder. Okay, so this is not necessarily specific to any diagnosis, although I would argue outside of the really more significant, either we're aware of a fracture in the proximal humerus, or a full thickness rotator cuff tear, or a shoulder that it has chronic, dislocation, subluxation, so chronically unstable. These techniques are really helpful to just about any diagnosis. So whether we've got a rotator cuff strain, a bicipital tendinitis, shoulder impingement, AC joint arthritis, any of these things. So the way that our body and our nervous system is designed is to be protective. So if the brain is getting some message from different parts of the system that is indicative of a potential threat or danger, then what the body's going to do is it's going to elicit a protective response in certain muscle groups. So if you've listened to, I think I've mentioned this in a couple of videos, where we're designed and we're wired with two sets of muscle groups. One that's very dominant and protective in nature. So when there's a threat, when there's inflammation in the tissue, when there is a strain because I moved, too quickly in one direction, or I did too much at the gym, or whatever it is, that muscle group is going to elicit and turn on and be ready to sort of protect us. And then on the other hand, you've got a group of muscles that are way designed, way more for postural, more endurance, and more fine-tuning of movement, okay? And I always like to kind of bring this up for all of my patients, regardless of which area of the body we're working on. So most of the time, if you've ever either had low back pain or you've heard about the treatment for low back pain, and we talk about core stability, right? If I have back pain, that means I have a weak core. Well, the way I like to kind of, teach people about all the different areas of their body is that every single joint, not just the low back, the lumbar spine, and not just the spine in general, but everywhere, we have a group of core muscles at each joint that are supportive in nature. These are the fine tuners of movement. They're postural. They help with postural. They help counter the really dominant forceful muscles, okay? So when you're looking at rehabilitation of any injury or any dysfunction, the goal is to downregulate that really hyperprotective response and then turn back on those fine-tuning core muscles, all right? So in the shoulder, the big dominant forceful ones are all the big movers, okay? That's the pec, the deltoid, the upper trap, the lat. So those are the muscles that if we've got some sort of internal derangement happening in the shoulder, an overuse, arthritis, a tendinitis, whatever it is, then those big movers turn on, and then the rotator cuff muscles are the muscles that kind of sort of center the ball in the socket. So when we go to lift up overhead or reach or do something, those rotator cuff muscles don't allow our ball to pop out of socket, right? So it stabilizes so that when we go to lift up, instead of getting this ball going rogue, it sort of pulls back down. So that's what I mean by these balance of forces, where you've got these bigger movers at every joint, but you've got the core intrinsic muscles at every joint, okay? So in a painful situation or a pain experience or a potential threatening experience where my body is registering something's not right here, at every joint, we have a position that the joint sort of goes to as a protective posturing or a safe zone. Okay, so these are the postures that you've probably either felt on your own or you see other people. So with the shoulder, it's sort of elevated and rounded, right? So if somebody has a hurt shoulder, when we put a sling on, we're pulling them up and forward, okay? And that is the intrinsic position of safety for the shoulder. The problem is that our positions of safety are not are not functional, right? So if we get stuck in these positions of safety, then we're going to try to navigate our world and move and use that joint. And we create a lot more stress because we're asking too much of a joint in improper positioning and things like that. So another example for like the knee would be a slightly bent position. So if I have a painful swollen knee or a tendonitis or something like that, my knee is going to assume a slightly flexed position because that's that position of comfort, okay? And then what it's indicating is that the hamstrings, the gastroc soleus, the big calf muscles, the deep popliteus, those are all those active, dominant forces that pull us into fetal position and protect us. And then the things like the quad sort of shut off and down regulate. Okay. So that's just to give you an example of a couple of things. So I want to demonstrate a few techniques to release trigger points in the shoulder. Again, this is not to take the place of you getting a workup by your physical therapist or if needed a physician, but it is to show you that if you've got some chronic thing happening, that these are helpful across the board to just about anyone. So I am a retired athlete, overhead athlete in a bunch of different sports, and I'm a right-hander, very right-handed. And so what has happened over time is that my right shoulder, sort of the ball, sits a little bit forward in the socket. That's just the nature of being an overhead athlete that was never sort of coached and trained in a way to kind of counter that. And so as I'm practicing and as I'm practicing physical therapy, not practicing sports that I'm not playing anymore, but if I'm using and generating force through this arm, I have the propensity to flare up sort of the anterior shoulder, okay? So a couple of things, and if you saw my last post and the post before, just wanting you to see resources and what they look like for trigger points and how to recognize where that muscle is, where the trigger points might be, and then how to do specific releases or where those trigger points refer pain. So I'm going to focus on probably about 5. One is the supraspinatus, which is the uppermost part of the rotator cuff. So the rotator cuff is 4 muscles. It is the one on top. It's the most at risk for impingement because of where it's located. It's one of those muscles that generally refers right near where the muscle is. So it sits right on top of, so here is the spine of my scapula, which is the bony prominence, and it sits just north of that, okay, if north is up. And so that muscle, oftentimes it elevates, it lifts the shoulder, or it initiates that movement, okay? So if you're having pain when you go to lift or reach or do something, and that pain is right here, you may have a trigger point in your supraspinatus. So if you watch the video that I did, I don't know where my balls are. Here we go. If you watch the video that I did where I leaned over in the doorway, that's an excellent way to also get that supraspinatus muscle, okay? The difference is that what I had coached before, where we're kind of closer to the neck to get scalenes, upper trap levator, this is going to be, you're going to be a little bit more out towards the shoulder, okay? Another way to get this muscle is with like a Theracane, one of those, Theracane things that you can pop right in there and just hold pressure. Again, with the trigger point release, you want to find the spot, hold moderate pressure for up to 60 seconds until you feel it go from, that pain response to just pressure, okay? So one thing you can do here, I like this. I'm in the lip of the doorway, and again, I have my 2 tennis balls and a sock. I'm going to go in. I'm going to lean all the way over to be able to access this area, okay? And I'm going to kind of play around with it and get a little bit more lateral right there. I've got it pinned. I've got that muscle pinned right against the spine of the scapula, okay? And I'm just going to let that release, okay? And again, if you saw my video previously, I'm just adding a little bit of mobility and movement to kind of deepen that release or quicken that release a little bit, okay? So let me show you that supraspinatus. Again, this is my trusty trigger point self-release manual. So you see it's right at the top of the scapula, and the referred pain is right into that lateral shoulder, right here. Okay, the next one is probably the most important muscle that I treat when it comes to shoulder pain, and specifically anterior shoulder pain. And it is crazy because it's the infraspinatus, and it is on the back lower part. So up here was the supraspinatus. Here on the back of the scapula is the infraspinatus. All right, apologize, I got a little water on this book. But the thing to note, okay, so here's the anatomical position of the infraspinatus, and you can see those dots, mean that lots of different trigger points in that area. But look at where it refers pain. One is to that medial border of the scapula. Lots of people have pain there. But most importantly is this front anterior aspect of the shoulder. This is a muscle who all of its referred pain is nowhere near where that muscle actually is, okay? So we can work all day in the front of the shoulder, but if someone has anterior shoulder pain and you are not addressing the infraspinatus, then you are missing the entire picture, okay? So what's interesting about the scapula too is we talk about different planes here, okay? So this lateral, medial to lateral plane, and this is, front to back, anterior to posterior. The scapula actually sits in what we call the scapular plane, which is about 45 degrees between those two. And the reason that's important is when you are doing the release to this infraspinatus, you're not going right up against the wall sideways, and you're not going right up against the wall like anterior to posterior. You're going to get in about a 45-degree angle, okay? Okay, let me just tell y'all, this is one of those releases. There are some trigger points that feel wildly productive. What I mean by that is it's a hurt so good, right? You hit the spot, it's like, oh, okay, that's what I needed. And then there are some trigger points that when you hit them, you're like, there is no way in hell this should feel this bad, okay? The infraspinatus is one of those. Whew. Now, mind you, I am not someone who is symptomatic right now. I have a history of overhead athlete. This shoulder is a little bit looser from all of that mobility. It's also my more dominant arm when I'm treating. So I've got that muscle pinned with the tennis ball. And what I'm feeling right now is this pain straight in the front. It almost feels like somebody's got like a poker in the front of my shoulder, which is wild because I'm not doing anything to the front of my shoulder, right? So this is that, post that I made yesterday about how complex pain is and how, the myofascial trigger points, while some refer right to the specific area, lots of them refer remotely away from where they are, which makes treatment, if you're, someone who doesn't understand, or you're seeing someone for treatment who doesn't understand these things, you're going to be lost, okay? There's this, idea that find the pain, look elsewhere for the cause kind of thing. Okay, so that's the infraspinatus. Remember, you're at a 45-degree angle. This is target rich. When you see these pictures, they have very specific dots or X's if you're looking online. Those are not necessary to follow. There could be trigger points in any of the fibers of these muscles, okay? So you're not looking for one specific area. What you're doing is you're looking for your spot, right? The spot that reproduces some familiar pain to you, okay? So that was infraspinatus. We're going to move to the deltoid, which the deltoid is one of these muscles that refers pain exactly where it is, okay? And the deltoid, you can see, is made up of 3 parts, right? It's one full muscle, but you've got 3 divisions: anterior, middle, and then posterior. And again, that anterior deltoid is often a hot spot for anterior shoulder pain. So I get lots of, bicipital tendinitis and things like that. And I'm not discrediting that may be the case. But again, if you watch my tendinitis videos, you can flush out and release some of the inflammation right at that tendon, but you've got to look elsewhere for why that tendon got inflamed in the first place, right? So when it comes to the deltoid, the good thing with having the 2 tennis balls in a sock is that it can access all different parts of the deltoid, okay? So the deltoid release is very simple, up against the wall, and you can kind of roll till you find a spot. then you can kind of quarter turn to the front to get that anterior aspect of the deltoid. I've got a good spot right there, so I'm going to hold it. And again, I can move that arm. I can do some different things to kind of knead that tennis ball deeper into the tissue, and that can be super helpful. Okay. When it releases, then I can roll, find the next spot. So I've got one on the lateral side. I can get one in the back. So deltoid is an easy to find muscle. It's easy to treat. It generally reproduces pain right where those trigger points are. Very helpful. So with a diagnosis of bicipital tendonitis or subdeltoid bursitis, okay? Well, that bursa is irritated because it's got too much force through there, okay? So freeing up some of this stuff can be really super helpful. The other thing that you can recognize as I'm talking is that it's not, we talk about these division of two different, neuromuscular systems kind of working in opposition and in support of each other. It's not that one's going to always be the one that has trigger points and the other one doesn't. Both of them can have trigger points, and often both of those sets of trigger points can create a lot of problems. So don't think, now generally the more dominant protective tonic system is going to be the system that feels tighter all the time. These are the muscles that you always feel like you want to stretch, the pecs, the upper tract. Oh God, everything's so tight. But that's not to say that the more fine-tuning postural muscles, the intrinsics, the core muscles are not also problematic in terms of myofascial trigger points. The last thing I want to show you, this is a super interesting muscle. It's called the coracobrachialis, all right? And, most of these muscles are just named for where they attach, okay? So this is the front of the body. They attach to the front of the scapula and then into the humerus. So look at where it refers pain. Anterior shoulder, and actually this is the back side of the arm. So we get this a lot where this muscle, the infraspinatus, the scalene, so again, kind of go back to my post from yesterday, and you can see how all of these different muscles refer pain and sometimes even paresthesias down the arm. But when we feel something down an extremity, we go to worst case scenario land, okay? Obviously, I have a disc pressing on a nerve root. I've got to go see my doctor. You go get a full workup. You get imaging. You get all of this stuff. And look, it's possible that you could have something going on in your neck, but that might not be the reason you're having symptoms down your arm, okay? So that's a super important thing. When it comes to the coracobrachialis, because it is super deep in there, the balls are a little bit more problematic. Like you can play around with getting those under and in there, but a lot of times it's just taking the opposite arm, thumb, and kind of whittling in there. So I'm pulling up on the tissue in the front, which is the pec and the deltoid, and I'm getting underneath that. And I'm going to kind of rotate my shoulder in and out, and I can even, the coracobrachialis lifts into flexion, which is forward ahead of you. So I can do that mobility, and when I feel that muscle kind of pop up under my arm, now I can hold pressure there. So you're doing those same trigger point releases, find the spot that reproduces your pain, hold pressure up to 60 seconds or until you feel it kind of fade off, okay? So that's an ideal zone. And a lot of times this vague pain down the back of the arm, if I go straight to that guy, that goes away in an instant. So it's just remarkable what we can do with myofascial trigger points. And I mentioned in my last post, I am not naive enough to think that myofascial trigger points are the only reason we have pain, but I would guarantee that every single diagnosis that includes some pain experience has at least some aspect of myofascial trigger points that's contributing to that. So if we can know that, treat it, lessen our pain experience, lessen the threat value, then our nervous system starts regulating a little bit better. It starts getting a little bit less sensitized to threats and things, okay? I didn't even get into the pec, which is a huge part of this, but that's for another topic and another time, and I hope that you enjoyed this. Thanks.